Welcome back, friends, and let's start now with Abruptio Placentae. Abruptio Placentae is premature separation of placenta even before labor starts, and this has different varieties. Again, it's a very dreadful cause of antepartum hemorrhage. Patient can be lost, baby can be lost because of antepartum hemorrhage or Abruptio Placentae as a major cause. So let's see the varieties. Revealed variety, most common, in which the blood insinuates between the membrane and the decidua and it is visible externally. Concealed variety, blood collects behind the separated placenta or in between the membranes and the decidua and it's not visible outside. But most of the times the variety is mixed, where some part of the blood gets collected inside, that is concealed type, and some of the blood comes out, that is revealed type of variety. So it's mixed, concealed and revealed both. Bleeding is always maternal. In both of them, that is placenta previa and Abruptio Placentae, the bleeding is always maternal. It is never fetal. Now there are classifications that to grade the way we have types of placenta previa. This is Abruptio Placentae, the classification. You have to remember the name, Page's classification. This is grade 0. Clinical features may be just absent, and this abruption is in small quantity, this placental separation which is premature before labor, and it gets diagnosed retrospectively when you see a retroplacental clot. So diagnosed by inspecting placenta after delivery. Grade 1, where there is external bleeding present, uterine tenderness will be present or not present, shock will be absent, and fetal heart will be good. So how a patient presents in abruption? Again bleeding, but here there would be pain. In placenta previa it was painless, causeless bleeding. Here bleeding is associated with pain, uterine contractions. So that's the difference in these two bleedings. Then there would be, if depending on if it is concealed or revealed, depending on the general condition will be dependent on the blood loss. Sometimes shock is obviously seen, but bleeding is not much because it is concealed type of bleeding. That way the general condition will not be always proportionate to the blood loss. That is again the difference in placenta previa and abruption. Pain, shock may be present, or blood loss is disproportionate and the general condition is disproportionate. Both the things are not proportionate. They were proportionate in placenta previa. FHS, because the blood loss we cannot really judge how much blood patient has lost, so sometimes even fetal heart can be absent in Abruptio Placenta. Usually PIH is present along with abruption, means whenever there is PIH, that increases the chance of patient landing up in abruption. That is why PIH will be present. So going back to the grading, in grade 1, external bleeding present, uterine tenderness present or absent, shock is absent, and fetal heart is good. That means the baby is in good condition, not much of blood loss. Grade 2, external bleeding present or absent, uterine tenderness will be present. It will be ++. Shock is not here, but fetal distress can be there, or even fetal death can be there. Grade 3, there is fetal death as a rule. If the patient has IUD in abruption, it directly falls in grade 3, and you may have associated anuria or coagulation defect, because you need to understand that if the fetus has died, that means more than half of the placenta is being separated, and that is why the fetal blood supply is got hampered, and that led to the fetal death. So the retroplacental clot should be on and around more than 500 cc's. That's the calculation. If fetal death is there, blood loss is much more than what is seen outside. It is most of concealed variety, and the placental separation is much more. That's why immediately you should arrange for blood. You should judge that this much blood is lost. Again, rule out coagulopathy in such cases. Because of so much of blood loss inside, the patient may land up in coagulopathy. So ruling out coagulopathy becomes a major important portion of investigation in case of abruption. And because of this blood loss, 500 cc of RP clot means blood loss is on and around 1 to 1.5 liters, almost thrice the weight of the clot. So much of blood patient has lost, so she may have anuria because renal blood supply getting compromised. So these are the things which tell us, because the blood loss is not always visible, so we have to take help of these clinical parameters to judge the blood loss. Presence of fetal heart tells us that blood loss, the placental separation is not much. Good urinary output tells us that she is fine. Because of presence of PIH, even though she loses blood, she may not land up in shock all the time. Blood pressure will still be normal. It will not be presented as shock. So we have to take help of these clinical parameters to judge the blood loss. So I hope the grading, the Page's classification is clear here. Sher's classification is also there. Grade 1, it is retrospective diagnosis, that once the delivery of the baby takes place, you see the placenta, you see a retroplacental clot, and it is grade 1 of Abruptio Placentae by Sher's classification. Grade 2, classical features present, that means bleeding present or not, uterine tenderness would be there, but baby will be alive. That is grade 2. And grade 3, fetal death is mandatory to call it as fetal death. So that is again big amount of RP clot, placental separation is more. Coagulopathy present or absent, both the chances can be there. So you have to focus in abruption on that first bleeding with pain, that tells you that this is abruption. Presence of PIH boosts or supports your diagnosis. Then how you evaluate the blood loss is whether the fetal heart present or not. Absent means blood loss is more. There is placental separation, almost 500 cc blood loss is there. Look for output. Output less means patient is landing up in anuria. Immediately when you are sending lab for blood group, cross matching, for arranging blood, immediately get the coagulopathy evaluation done, BT, CT, PT. Look, rule out that patient is yet not in DIC or in coagulopathy. So these are major steps in management of abruption. Now for the causative factors, this is a MCQ that abruption occurs in all except, and the options given are smokers, alcoholics, cocaine abuse and folic acid deficiency. So we are going to see the causes, but any guesses for this? Alcohol doesn't increase the risk of abruption. So now let's see what are the risk factors in which patients we will find abruption more commonly. Increased maternal age and parity increases the risk for abruption. Preeclampsia goes hand in hand with abruption. If preeclampsia is there and patient bleeds antepartum, think of abruption first. Abruptio placentae, first take patient's BP and see that whether she has hypertension. Hypertension, preeclampsia and abruption always together, almost always together. Always confirm it by doing a protein test for urine and you will find protein and that says that yes, there is preeclampsia. Smoking increases the risk of abruption. Trauma, any sudden blow on her abdomen will lead to placental separation. So trauma, any history of fall. So patient walking in with pregnancy, with bleeding, tender uterus, woody hard, ask her whether there was any history of fall, any trauma, abruption. Sudden uterine decompression, like suppose patient has polyhydramnios, the cavity is distended with lots of liquor, rupture of membrane, liquor suddenly drains out, placenta will get separated because uterine cavity shrinks in size, that lead to placental separation. Or in twins, first baby delivers, suddenly there is uterine size decreases, that leads to placental separation. So that can also increase the risk of abruption. Hereditary thrombophilias, antiphospholipid syndromes, folic acid deficiency, PROM and even cocaine substances. PROM the same cause, liquor coming out, cavity decreasing, decompression leading to abruption. So these are the risk factors in which you have to always think of abruption. In obstetrics, there are certain conditions which should be in your mind all the time. First is ectopic. Whenever you early pregnancy and bleeding, think of ectopic. Rule it out, then go ahead for other differentials. Patient coming pregnant around second and third trimester, walking in with bleeding. If you know ultrasound, if it is there, placenta is up, abruption. Placenta is low, placenta previa. So these are few things which should always be there in your mind. Clinical features. revealed and concealed, both types. Revealed usually comes with bleeding and there is little discomfort. The pain will not be much. But in concealed variety, pain will be intense because the blood is getting accumulated inside the uterine cavity. In revealed variety, general condition of the patient will be proportionate to the blood loss. So, whatever blood loss you are seeing, accordingly you will find her pulse and blood pressure. In concealed variety, it will not be associated. It will not be proportional. Shock may be there, may not be there. Again, I am stressing on this point because MCQ can be asked. Because if abruption is not with the, if abruption is not associated with PIH, then there may be shock in concealed variety. But if it is associated with PIH, the blood pressure may not fall so low that it's obvious shock. But still, patient has lost that much of blood. Uterine height will be proportionate to the gestational age in the revealed variety because blood loss is coming out. In concealed variety, the uterine height will be more than the gestational age because the blood is getting accumulated inside. Fetal heart usually present in revealed, but in concealed, the clot itself helps in more and more placental separation. So usually fetal heart is absent. HB fall or deficit will be again proportionate to the blood loss in the revealed variety. In concealed variety, HB is less, much deficit is there, even though blood loss is not that much seen outside. Anuria or oliguria may be present in case of concealed. Urine output will be diminished because much more blood is lost inside the uterine cavity. Complications, again maternal and fetal. Maternal complication, hemorrhage, shock, blood coagulation. Certain things in abruption, PIH, and then in management ruling out blood coagulopathy. You have to always remember DIC and coagulopathies in case of abruption. So many a times patient lands up in coagulation disorder. Renal, oliguria or anuria because of blood loss. After delivery of the fetus, PPH is very common because consumption coagulopathy, again leading to PPH. Puerperal sepsis is very common in both placenta previa and abruptio, both. Sheehan syndrome, in which because of sudden blood loss, because of PPH or this, there is decreased blood supply to the anterior pituitary because the blood supply is that way. And because of that, there would be pituitary necrosis and that will lead to failure of lactation and then secondary amenorrhea in these patients. So Sheehan syndrome, we see it commonly in PPH. It can also be seen in abruption. Fetal death, almost 50 to 100%. There are reasons are like prematurity or because of anoxia. Sudden bleeding stops towards the fetus or blood loss is there. Because of maternal blood loss, fetal blood circulation gets hampered, and because of that, fetal death is quite commonly seen in abruption. Management. Remember, there is no expectant management in abruption. Once it is abruption, we have to terminate the pregnancy. And now termination depends on the cervical status. Once you confirm that yes, there is abruption, findings like pain, bleeding, either concealed variety or revealed variety. Uterus you will examine, you will find that it is woody hard. Uterus is not getting relaxed in between contractions. Fetal heart, if present, keep looking, continuously monitoring the fetus. If fetal distress, sign of fetal distress, go for cesarean section. If fetus is coping well, if the fetal heart is good and cervical status is good, she is likely to deliver within next 6 to 8 hours, we can proceed for vaginal birth. Early ARM is the rule. As soon as the cervix is around 2 cm, you can do ARM. That drains out the liquor and helps the uterus to shrink in size, and this helps in, to some extent, it will restrict further placental separation and further bleeding. That is why early ARM is the rule if we are going ahead with vaginal delivery. So as soon as you do examination, PV examination, if possible do ARM quickly. Blood stain liquor, one thing, confirms your diagnosis. Second, stops placental separation further and leads, again it enhances labor process, it augments it. So it helps in many ways. Put a catheter to monitor urinary output that keeps telling you about her blood loss and about the renal blood flow. So it's always a good thing to have a catheter in abruptio patients. If you feel blood loss is much more, it is concealed type of variety, arrange for blood transfusion as well as blood components depending on the coagulopathy report. So it is simultaneous thing that correcting her hemodynamically, maintaining the coagulation profile intact and emptying the uterus. If delivery is seen in next 6 to 8 hours, always go for vaginal delivery. Avoid cesarean section because of disturbed coagulation picture. But in case if there are associated obstetric indications, you have to go for cesarean section. If you see cervical status is too bad that she will not deliver immediately, then there would be chances of landing up in DIC, then you have to go for cesarean section. But the rule of thumb is, before going for any operative procedure in abruption, check twice that her coagulation profile is normal, because otherwise she'll land up in DIC because of operative procedure. She'll lose much blood. So in short, there is no role of expectant management. Hemodynamically, the patient has to be stable. Coagulopathy should be ruled out. If there, then we have to simultaneously reposit blood and components to avoid patient landing up in DIC. Vaginal delivery is preferred mode of delivery. If possible, go for it. Early ARM is the rule. Even in case of the IUD, we have to do sometimes cesarean section if the Bishop's score is poor and delivery is not expected in next few hours. Before going for cesarean section, for any of these indications like obstetric indication or poor Bishop's, poor cervical score, previous to LSCS and more, in that case we should always rule out that there is no coagulopathy, and then only the patient is taken for cesarean section. So these are the important topics in management of abruption. We will again revise the topic that the separation or the difference in these two. In placenta previa, the patient will come with bleeding PV, but it would be painless, causeless, fresh red color. Patient will suddenly find herself in pool of blood. In abruption, she will either have history of PIH or there would be history of fall or sudden blow. Patient comes with bleeding PV but with pain in abdomen. When you examine this patient, pallor in placenta previa will be proportionate to the blood loss. In abruptio, pallor will not be proportionate. In abruption, you will usually find the BP is either high because of presence of PIH or sometimes there can be presence of shock. When you examine the patient per abdominally, you will see that in placenta previa, uterus is proportionate to the gestational age. In abruption, it may not, in concealed variety. Malpresentations are quite common in placenta previa because of low-lying placenta. So there would be either malpresentation or the head would be floating because it can't get engaged because of the placenta situating there. In abruptio, uterus will be stony hard, woody hard. There would be tenderness and uterus will not relax in between two contractions. That will guide us that this is most likely abruption. Fetal heart would be present in case of placenta previa. Fetal heart sometimes is absent in case of abruptio. PV examination not to be done in labor room in placenta previa. In abruption, it has to be done immediately. Put a catheter, see output, confirm that proteins are there, and then early ARM is ruled. Mostly go for vaginal. If contraindicated, then go for cesarean section. In placenta previa, if it is minor degree, we can think of vaginal delivery. If major degree, cesarean section is the treatment. Blood has to be kept ready over here depending on the blood loss. Coagulopathy are rarely seen here. PPH, both the cases they are at risk. In abruption, always rule out coagulopathy. That's the first investigation. Maintain renal blood flow by giving IV fluids, mainly crystalloids, and if required blood transfusion. If we see that fetal heart is absent, means 500 cc, then immediately transfusion blood should be asked for and immediately transfusion should be started. Depending on the blood coagulation report, component should be replaced and simultaneously emptying of the uterus should be done. So I hope the topic is very clear to you and this will help you in your exams. Thank you.